everybody. Welcome, welcome, welcome. Hello, Alicia and Jennifer. Boyd here, your webinar host and driver for tonight.
Yeah.
Alicia's got some interesting things going on down there in the bottom of my screen. She's not feeling too good today. But she's coming, she's attending. So you can say a little bit, but we're going to save your voice for your questions, I guess.
This is very hard for me, guys. Just letting you know to not talk.
I think the transcriptionist can still figure out what you're saying, so I think we're okay. Don't you think? So
if they can figure out a doctor, they can figure out her. So,
well, ladies, thank you for joining me here on our September CCO Q&A webinar. If this is your first time, welcome to the community. And we wanted to say just a shout out for our first timers. We'll probably hear from you in a couple seconds. But this is a general webinar about all things medical business, medical certification, medical coding, billing, and practice management relating. So I put the screen up so I can just read it so I don't have to make mistakes. So I'm going to try to not read it and just talk to you guys and tell you we cannot hear you in the chat if this is your first time on GoToWebinar. However, if you want to give us a chat message or a question, we're going to have the team in the back working on that as we go. Maybe we'll save it to the end and actually answer it in our Q&As after the webinar at the end at 90 minutes. So basically, we're going to start off tonight with a poll called, what is your status in medical coding, billing, or similar medical business related job? And we're going to try to share this poll. And there you go. What is your status in a medical coding, billing, or similar medical business related job? What's your status, Jennifer?
I am certified and looking for a job, but we also have looking at medical coding as your career. Are you employed? Do you need to improve your current job situation and you want to earn a new credential, or you're just not pursuing any employment at this time?
Yep. So what's your status there? So what's my poll say? We have 70% voted. That's good enough for me. So we're going to close the poll. We're going to share the results. We have, what do we have there, Jennifer, if you want to read them off for us?
Well, let's see here. We have, it's kind of covered up, sorry. Sorry. Let me move my screen over a little bit. We have 29% of our attendees are looking at medical coding as a career, but 30% are employed, so that's great. 14% are certified and looking for a job. 24%, I love to see that one. They want to improve their current job situation and earn a new credential. I love that. More power to you. And 3% are not pursuing any employment at this time.
Awesome. Great. Then
yes.
I'm going to hide the poll here and go back to our normal wonderful screen sharing and go on to the next one. So this is our agenda for today, and normally this lasts for 90 minutes. So we're going to just go over some CCO news and recent graduates. Then we're going to get some Q&A from the CCO community, and basically these are questions that you see on your screen with Jennifer and Alicia that have been pre-prepared. So Jennifer, tell us a little bit about what you're going to be covering.
Well, I'm going to do a little bit, it's kind of a quick segment, but we can talk about some things that we have about studying for the CPC exam. And then osteopathic manipulative medicine, or osteopathic manipulative treatment, along with an E&M on the same day. And coding, my other one's actually, that's an error there, ASC coding. So looking at ambulatory surgical coding. So
I got really good topics.
Yes.
Which is really depressing that you, I'll keep my voice. Home health, we get a lot of questions about home health coding, surgery coding errors, what to watch for. And I, not Jennifer, get to talk about long-term drug therapy. Actually, her topic is more exciting than her other
Nah.
It's all good. Oops. Now I understand why it gets away on us. Okay. So again, we're going to go for about 60 minutes, and then we're going to stay to the end, please, to get one of our prizes that we give away every webinar. We're going to talk about that here in a second. And again, you can ask a question anytime. We can't answer every question, but if it isn't selected, we encourage you to go to cco.us and /topic request and ask your question there, and we can take care of it in a little bit more detail for the next one. So a lot more people can see what's your question and learn from it as well. All right, so this is again some of the giveaways that we're going to be giving at the end, our review CPC Blitz, perhaps a telephone interview, question, chat, you know, kind of thing with either Jennifer or Alicia.
Not right
or
now. Huh? Not right now with Alicia. Yeah, wait a week or two.
Yeah, exactly. We'll get her some meds, and she probably even prescribe her what she needs herself. But lastly, CCO Club, that's also going to be an option that's going to be available for you if you win. And if you need CEUs going forward, they are always available in our CCO Club, and we'll be talking about that throughout the webinar. And we have a lot of great webinars that we do for the club that goes on every week. We have a lot of billing and coding Q&As, and then we have a lot of extended product support, but more details are at cco.us/club on that. Cool. All right. Jennifer, I'm going to ask you to do the graduates here.
I will do the graduates, yes.
So
Alicia can do the golf claps in the background.
We're going to find out who's new on the webinar here in another survey poll. But if this is your first time, what we like to do is celebrate the people that have taken CCO education and have acknowledged that we help them. So we just want to return that back to them and say, hey, these guys did great, and they let us know. So if your name isn't on here and you've used our education to help you pass or get a certification or excel in any way in your job, let us know by going to the site, and you can fill out a topic request there and let us know.
Yep, so we have a couple different products here that we're going through. So the CPMA, we're looking at the auditing. Recent auditors are Amrita Banerjee and Barbara Manasco, sorry. They use the CPMA Blitz. And then we have some CRCs, which is a really great new field, Alicia's favorite. That's our risk adjustment coding. Kelly Ruffner, Abdul Rahim, and Kamoy, they've all recently passed with the CRC, which is great. That's a great accomplishment to do the CRC exam.
Awesome. And next one.
We have Alia Kogan, who passed her CPC, which is great, and Angelica Navarro is a COC, so pass that exam.
Great. And I didn't check. Hopefully, we have audio. Everybody's cool. I didn't check my
I didn't even pull up my chat.
Yeah, exactly. I assume that they'll be fine. Okay.
I forgot about it.
I'm watching the chat.
Okay. Okay, good. So here's our prepared questions, and we're going to get started with September Q&A questions with Jennifer. And this is Jennifer's first one. I'm going to just drop my camera off along with Alicia, and we'll be back here in the background.
Sure. We had a student submit in that they're a full-time worker. So what is the suggested way to study if they want to take their test in the next 3 months? So what's the best way to take advantage of so they're looking at timing on the test, but there's a lot of different ways to take advantage of that, especially when you know you have plenty of time to study. So working all day, remember, that's not just 40 hours a week. You got to drive there, you got to get there, you got your family time to account for, dinner, evening, homework, all of that stuff. You got doctor's appointments, grocery shopping. So when we think it's a full-time job, I'll just study in the evening. Well, we know that there's a lot more to it than that, a lot more to everybody's life than just that. So you want to be able to think about what time you can devote, because we know all those other things come up. So if you're looking at taking just a refresher, like one of the Blitz packages, you just need to brush up a little bit because you've been out of the field for a little while and you feel rusty, or you started at the beginning of the year and now you're coming up on the end of the year and you don't want to buy new books, so you want to try and take an exam. Or if you're doing an online course, whether it's through APC or CCO, they run about the same length of time. Or if you want to look at that set time schedule. So like everything else you do daily, you had to get in a habit of flossing, you had to get in a habit of exercising every morning. We want to do the same thing with studying. So you're looking at a routine. You want to try and make it something that you're going to devote that time to every day. And then it becomes a routine. And then it's not work, it's not a chore, it's not difficult, and it becomes easier for you. So one of the best ways is setting some time on your calendar. Putting in, I actually have a paper calendar. I was amazed, Boyd was amazed actually that I use one. And I actually saw a student in my class the other day, she has an agenda calendar as well. So I know most people have it on their phone, but you know, making sure that you're marking time, letting the family know, letting your husband or your kids know, this is mom's time, this is dad's time right now. We need to, you know, I need to devote to my studying. I actually have a sign I hang on my door saying, you know, I'm working right now. And whether you need to actually lock your door, possibly, turn off the phone, use the do not disturb feature of your phone so you're not interrupted by text messages or stuff. And then you'll get in that routine, you'll get in that habit. So what are you going to study in this time? You're going to look at reviewing those guidelines, refreshing yourself on those guidelines because they're so ever important, marking your pages, writing what page number that guideline affects if it's ICD-10, you know, highlighting, doing your tabs, definitely your bat. If you haven't batted, you know, if you haven't bubble highlighted and annotated the CPT information, that's an easy way to quickly on a test be able to extract that information really quick is if you have the BAT technique, if it's already done up in your books. So reviewing those CPT sections perhaps. Taking practice exams. A lot of places offer them, whether you purchase the bundle from APC and comes with multiple. We have them free on our website on CCO. There's a lot of places out there that offer a CPC exam. So take one for practice. What areas are you struggling with? And then go back and restudy those areas until you're comfortable with it. Reviewing, go to some kind of free quiz websites for anatomy and physiology and medical terminology and quiz yourself. See how well you can come up with these answers off the top of your head, because that's what you're going to have to do in on that exam if we're talking a CPC exam. But a lot of the exams hold anatomy or your terminology you're definitely dealing with in any exam you take. So being able to familiarize yourself again with the anatomy and I've got tongue-tied tonight, anatomy and physiology or your terminology, you know, making that fresh and clear in your brain. Watching YouTube videos. Do you go and pick up your kids every day from the bus and you kind of got to wait in line? Pull up a YouTube video, either a CCO or a medical ones. Alicia loves those, you know, being able to watch a procedure. And it might make more sense to you then. And you can, if there's an area you're having difficulty with, you can go, oh, that's what they're doing. Okay, now I understand what they're saying in that CPT code. I get it now. So even if you're just spending 1 hour every night, it doesn't seem like a lot, but especially if you have kids and after the kids are in bed, 1 hour. And if you can devote that just 5 nights a week, you don't have to do it all 7 nights a week. Make your notes on the illustrations. If they're all in the book, they're all there for a purpose. So use them, utilize them, you know, review those guidelines, review the ICD-10 guidelines, review HCPCs. That's a pretty easy book when it gets down to it. But those modifiers that are in there, there's 4 pages of modifiers in the front and back of a HCPCs book. Look them over because you're probably going to see them on a CPC. So setting aside, if you can do more than that, then you're going to do it a little bit quicker and be able to know this information a whole lot quicker, spending more time on those practice exams. If you do like each weekend, so this person had 3 months. So if they study for a little bit and probably like the last month beforehand, take 1 hour and answer 30 questions. Do a practice exam with 30 questions. That's it. If you can do 30 questions in 1 hour, you can do 150 questions in 5 hours, leaving you that extra 40 minutes left over to go back and answer that question you didn't quite get. You know, go back and review it. Make sure you bubbled on your Scantron and all the exact areas that it had to be. So giving you that a little bit extra time. So if you can do 30 in 1 hour, that's a good thing to shoot for. And like me, I'm sorry, Alicia and I, we have lots of kids. I actually work a couple other jobs besides this one. I'm in a master's program. I'm one of those people who say, I am just way too busy. So take advantage of your lunch breaks. Your 30 minutes at work. Eat at your desk, but have your book in front of you. Review it. Go over some information. I read the whole Game of Thrones series on my lunch break. So it took me a year, but that's what I spent my lunch break doing, is reading a book. Waiting for that afternoon or the morning bus, spend a little bit of time there. I'm actually studying for my CDEO exam, and I bring the study guide with me to the bus every night when I go to pick up my son every day. So I spend 15 minutes going through that study guide every day. Sunday school class, you know, and it kind of time where you're just sitting there waiting for somebody. You bring your mother or your father to a doctor's appointment. You got time then, you're sitting there waiting while dinner's cooking. It takes 30 minutes, 25 minutes, 15 minutes. You got some time that you could possibly devote to that. Even a 30-minute increment is easy to find, but that devotion is key. So being able to come up with the time, you're going to feel stressed for time. So if you can either practice those 30 questions in 1 hour, that's a good goal to shoot for. But giving you that familiarity with where everything is, starting to look it over again. Maybe you do dermatology for your job. Well, then you need to get familiar with where everything is in the neurology section. You know, there's spine and neurology as well. It's not just neuromuscular. So getting used to where things are in the book, being able to know different terms that might be used for medical conditions. And another thing to look at, a lot of people don't know this, but your local chapters offer CPC review exams. A lot of them do, CPC review classes. So it could be 4, 6, 8 hours of a day where you go and they're going to have an instructor or somebody teaching to you places where people have problems with the exams, going over things you may not think of, going over those test taking tips, going over, they might even offer a practice exam there. I know ours does. So I know a lot of people start using that as well. I've actually shared my practice exam with other area chapters, so they might be looking into that too. So it is a good area to look at, a good thing. And if yours isn't offering it, ask them. If they can find somebody to teach one, ask them if they would instruct one. See where maybe another chapter is an hour away from you, see if they're offering one. That hour would be very good in your day. And definitely, as with anything we do in coding, repetition is key. So practice, practice, practice. That's the best way to fit this in and achieve it in a goal that you've set. So.
Great tips. One thing I will add, in personal experience, I had to learn Portuguese in my 40s because I decided that I was going to be investigating a Brazilian woman from Brazil, and I had like 2 months in order to basically go back and court her. And when I first met her, we had basically about 10 words in common. Basically, the long story short is that I discovered through my own research is that as soon as you wake up in the morning, if you take out those, before you do anything else, if you go and you start whatever you're working on, work on your practice, whatever it is, all the things that Jennifer went through. If you do that at the very beginning of when you wake up, and also before you go to bed, those are the times when your brain is going to be most susceptible of you remembering that stuff. So just wanted to add that. That worked for me, and I still use that to this day. And yes, the marriage still has strength and has produced 2 kids, so it'll work.
It's going strong. So I know that we've. Oh. Boyd.
Hit the wrong button again. There we go. Thank you. From time to time, you know that we have promotions here at CCO.US, and this is one of them that's going to be expiring here in the next couple of days, and it's our end of summer sale. So you can go to cco.us/end of summer sale and find out all of the discounted courses and review blitzes. It's not across the board, but there's select items that are on sale right now. So this is a great time to take advantage of that while we have that available for you guys. Just want to point that out to everybody. And I think we're ready for Alicia.
Yay.
All right.
Want to take
I'm
a
going to
stab?
do good. So this question came in, and I was really excited about this because I got to do home health, and so that's kind of near and dear to my heart. But the person had said, I'm interested in applying for a job in home health, and there's a lot of jobs out there for home health coders, but was not sure what to expect. Are you able to tell me what's the difference in home health coding than, say, working for a family practitioner? It is actually very different. What you're going to find is that the reason that you code is very different. First thing, note that most people think that home health is only for Medicare patients, geriatric age patients, but that's not true. There is a large area of home health that is in carries all ages. Let's say a child has a digestive disorder and ends up getting a colostomy, and there needs to be education and so on and so forth, and the parents can't get the child to the doctor easily and stuff. So home health comes out and does training and education. You know, doesn't matter if the kid's 12 or 20, or you know, what we commonly think of it is as older. But there is a criteria for home health, and this is really important, and it will help you understand how home health coding is a little bit different than, say, what you're going to see in a general practitioner. The first thing and the most important thing is that the patient has to be homebound. So to be homebound doesn't mean that you can't get out. So say you want to go to church on Sundays, say you want to try to go, you know, once in a while to get to the beauty salon, get your hair done, things like that. That it's okay to have a reason to go, but it has to be very difficult for you to be able to go. And you rely on others. And if those other people are not there to assist you, then you can't do it. In other words, when you can't make your doctor's appointments, when it's very difficult for you to get out and go to your doctor's appointments, then your doctor appointment comes to you, more or less, with home health. Now, this is a criteria that's set up through Medicare and Medicaid, okay? And again, Medicaid will help pay for home health. That's all ages. The other thing is that you need to require skilled care. So with skilled care, that means that you need a nurse, so a clinician to come and assist you, or you could have a CNA that comes and assists you. But the key is that it's not going to be full-time. This is a temporary event that's going to happen. If you if it meant that you needed to be put in a skilled facility, that's a longer period of time. Now, it's very important that you know, too, that to be qualified for home health care, you have to have seen a doctor recently, because they're going to sign off on what the clinician comes out, the RN, the nurse that's going to come in and be your caseworker, is going to establish a plan of care and what they feel that you need. They'll do an evaluation. They'll write that up in something called an OASIS. They'll send it to the doctor for a plan of care. Then that doctor will sign off and says, yeah, I agree with this plan of care. And then only an approved home health agency can be used. You can't just have anybody come in and assist you with home health. So if we scroll down a little bit, then we're going to go into more depth of what actually makes home health different. The main thing I wanted you to understand is that it's only for 60 days at a time. So let's say they know that probably you're going to need this for 3 months, not 90 days, but the OASIS only extends out for 60 days. Excuse me. And the other types of care you're going to get are things like physical therapy, occupational therapy, and speech therapy. There's lots and lots of examples of things that would incur you needing home health. And I'll tell you some more of those. But with all of that being said, excuse me, the scrutiny for home health is a lot different than what you're going to see in a general practitioner's office or any other area of coding. And there's several reasons why. One of those is that when home health kind of started and hit its peak in the 80s, people were getting rich. And some of it was out of ignorance and some of it was out of deliberate fraud and abuse. And it was an easy way to make money off the government. And so the government recognized this, that it was being abused. And in the 90s, they really started cracking down. In the 2000s, it became even harder. The scrutiny was really, really severe. So you're going to be working with or under the thumb of, I don't know if that's the right term to say, but these are the organizations that you're going to be very aware of in home health. You're going to have RAC audits, MAC audits, ZPIC audits, and MIC. And I went ahead and wrote what each of those were. I also put a lot of footnotes here for you to go do your own research. So if a RAC is from the purpose of a RAC audit is that they're looking for improper Medicare payments. And it's usually fee-for-service Medicare plans. MACs are Medicare administrative contractors. Okay, so the MACs will do audits and investigations. They'll look at everything, but you don't really see what the MACs are doing. It's almost like it's preventative, okay? Whereas RAC audits, they're trying to recover money that was taken because of fraud and abuse. Okay, scroll down and we'll look at the next one, which I think is the ZPIC. No, yes, that's Zone Program Integrity Contractors. And they're trying to prevent and detect fraud and abuse. Now, they can, they're not conducting random reviews. It's always very, very focused. You know what's going to happen, but they suspect fraud and abuse before they come in. And then the other one is the Medicaid integrity contractor. So it's kind of like the Medicare ones. But what makes these different is these guys are being paid to find mistakes, and they will find them. So I don't want to deter you from going out and becoming a home health coder. It's a lot of fun. It's exciting with the people that you get to work with. But it can be very, very intense, and the scrutiny is very high. So you're going to learn quickly and be be very aware of staying within the guidelines, both with COSEDs. You're going to be using ICD, CPT, and HCPCs. Now, there was a great article that I pulled out of Coding News, and I footnoted it there. And I went ahead and copy and pasted this. So I footnoted it, but I left it in italics because I wanted you to let it know, wanted you to be aware that it came from this article. I'd urge you to go read the article. But they gave an example of a particular code. So if a person is getting home health and they've got osteoarthritis, okay, unspecified site, but the PT comes in, physical therapy says, well, they have osteoarthritis of the right shoulder. Now, we're trained to always get to the highest specificity no matter what. In home health, you're looking at all of this documentation, your physical therapies, speech therapies, OT, your MSWs, which is medical social workers and stuff, any type of care that a patient can get at home. You're going to be acquiring diagnoses from that, and then they'll be sent off and approved by the provider. But the key is, even though the physical therapist, which is an approved provider, states that it's osteoarthritis of the right shoulder, if the provider, the doctor, doesn't state that, your hands are tied. There has to be a query. It has to be notated by the provider, or you cannot use M19.11, that higher specificity. I'm sorry, 0.011. So you're required to use the M19.90. But as a coder, we strive to go to the highest specificity, and we see that documentation and we will code it. And that is not proper. So scroll down just a little bit more, Boyd, and we'll see the second part of this and wrap this up. Again, it comes from the coding clinic guidance that tells us that it has to stay as unspecified unless we have the provider stating this. And that's just one of many examples in home health that you can make a mistake. But know that you're dealing also with durable medical equipment, HCPCS codes, and I would say for the most part, a lot of errors and things happen with those. So it's important that the documentation is very, very good, and that your understanding of the coding guidelines are top-notch. Because unlike working for a family practitioners, there are guys out there looking for you to make a mistake, because so many people try to or get involved with fraud and abuse. And so they're looking for you. But it's a fun area. I'm sorry, I just don't want you to think that it's not a great area to be a coder. It's an excellent, and there are certifications. The APC does not have one, neither does AHIMA, but there are several other organizations that have one. And this Trish Twombly, she's an HCSD, so you go look that up. Also, you can look up home health credentials. Like I said, several organizations that you can get credentialed with them. They really like to have clinicians, because an RN can also fill out the OASIS. But there's a lot of CDI in home health as well. It doesn't mean that you have to be a clinician, but sometimes that's what they're looking for, so you can have that dual role. And that's it. I made it through.
You did. Thank you, Alicia.
Sounded really good too.
You did. I'll take us straight into a poll here, which is the next one. Which area do you feel you need more education in, guys? Billing, CPT, ICD, maybe a specialty credential? Write which one in the question box if we obviously don't have it on the survey. Or is it something else you want to focus your time on? Write that in the question box as well. Let me fix that, and you take the time out to vote there. We've got 60%. It's always funny. I can't even imagine how many. I don't even have like my fingers on one finger all the times Alicia's been sick. So this is pretty amazing, Alicia, if I think about it. Not even on one hand in 7 or 8 years that we've been working together. Okay, so we've got the poll done, I think, and we're going to close it and then share it. So billing, we've got 23%, CPT is 38%, ICD 21%, specialty is 17%. Do you see any of the answers there, Jennifer, that you want to share?
Yes, I do. Yep, we have a CPMA, and I love Valerie's answer. She's just getting started, so all of them. That's great. I love that. Billing. Somebody's looking at specifically like physical therapy or occupational therapy, and CPT itself. So yeah.
Awesome. Great. Hide results. And our next one is Dear Jennifer.
Yay. So we had somebody come in with a question about, I'm going to try not to tongue tie this, osteopathic manipulative medicine.
Better you than me.
And an E&M. And, or, you know, if you look it up in the CPT manual, you're going to look under osteopathic manipulative treatment. So it's a little, you know, meaning the same thing, but people use different terms. And as we see that a lot in looking at, in learning this, people know a lot of different terms for things that we don't. So when is it medically necessary to bill for the E&M code when a patient's being treated for, they're saying their example, here's low back pain, and the decision is to perform this osteopathic manipulative treatment on them. And should they use a 25 modifier? So first, some of you are probably wondering, what is osteopathic manipulative medicine? So that medical providers are going to do a manual therapeutic application of pressure, or they say force, into a body area. It's not chiropractic. A lot of people think that that's chiropractic. Chiropractors use specific modalities, specific procedures, just like occupational therapists and physical therapists use. So it's similar, but this you're looking at typically a DO, a doctor, an osteopathic doctor is going to do these kinds of treatments typically. There are other people qualified to do this as well. So it's also called, osteopathic manipulative treatment. So it's treatment used on the structural and functional issues that somebody's having with bones, joints, muscles, tendons, tissues. So a specific area in the body. And what they're trying to do is restore that function between the neuromuscular skeletal system and the whole rest of the body. Because as we know, a lot of times if you have one area that's bothering you, the rest of the body kind of compensates for it. And so it can kind of mess up, your whole chi, messes up your whole flow of everything there. So, and it's meant to achieve and maintain health of the whole body. That's what they're looking at, is a whole body health, not just you go to a doctor because your back hurts. They're not just trying to help your back. They're trying to influence that area of your back so the whole rest of your body can function as well. Especially coming from orthopedics, people with back pain really have a problem with a lot of other problems as well. So this type of treatment is used for all different kinds of illnesses. We're looking at arthritis, headaches, stress injuries, pain in your back, your shoulders, your knees. So if this treatment is the decision of the provider after they do the evaluation management. So they're going to follow all 3 steps of the E&M process. They're going to do your HPI. They're going to do the exam. And then in their medical decision-making process, they say, you know what, this treatment really is going to help the rest of your body for this problem that you have. And they do that on a case by case, a visit by visit. That's not something typically like in the area I deal with all the time. We'll come back next time. If it's still bothering you, we'll give you an injection, right? And so this is kind of I really think this is going to help you today. Maybe next time you'll be better, but this is what we're looking at. So the codes we're specifically dealing with in CPT is just one small range of codes, 98925 to 98929. They're in the medicine section. So you're dealing with different regions of the body. So you will only ever be billing one code per data service. And it depends on how many body regions you did. So you're not going to bill 98925 twice, or times 2, or times 3, or times 4. You're going to bill for however many body regions they did, and you're only ever going to bill that one code. And when you're looking at, you're wondering, okay, well, you got 10 body regions. Well, what are they? Well, those are described in our ICD-10 codes. So we're looking at a segmental or somatic dysfunction. So that's what they're looking for, somatic dysfunction. The head is one region, cervical, thoracic, lumbar, sacral, pelvic. Lower extremity, something affecting all of the lower extremity, all of the upper extremity, your rib cage, or the abdomen and other regions. So those are up to your 10 areas that they're looking for, and that they're going to do. You have a somatic dysfunction, and then they're going to manipulate that area. So you would append the modifier 25 with an on the E&M. So you only put the 25 on the E&M, of course, if you're going to bill that in conjunction with one of these 98925 through 98929 codes. But your documentation, this is why it's so important. Remember, Alicia's talking about home health, had a lot of those things coming back from fraud and abuse. They're really looking at these codes too, because they need the documentation to prove that they did that evaluation and management and now they're doing something else. So it needs to say in the documentation, the region that was identified during the exam that has been diagnosed with some type of somatic dysfunction, whether it is skeletal, arthritic, myofascial, visceral, or related to some kind of lymphatic disorder, or it's going to affect some other kind of element in the lymphatic system if we don't, or neural system or vascular system, if we don't correct this. So, and it's possible to include a note specifically detailing those regions, but it also should say what techniques you used. And I give another website at the very end, so you'd have the information, 40 different types of treatments that they can do. So which techniques did you use? And then how did the patient tolerate the treatment? That is probably one of the most important regions or answers they're looking for, is how did the patient do after you did that treatment. So the American Osteopathic Association gave some tips that they say for documentation. Always separate the E&M services from the procedure note. That's their tip. You know, everybody, of course, does things their own way, especially when you have templates and things like that in EHR nowadays. But they suggest to separate them so that you can identify that E&M source and that manipulative treatment. Never bill more than one E&M service per day per physician. It's funny that they have to include that as a tip, but what if somebody in the practice saw you, but somebody else is best at that technique, so they want you to see them? Well, that other physician now can't bill an E&M as well. So I guess, you know, that's why you do one E&M. And you're not going to use modifier 59. Apparently, that's what a lot of people are doing with some of these common errors, is it's a 25 on the E&M service. So the E&M gets a 25, and then you include your manipulative treatment code. So, and actually, this came off of another website that I have. This was an article, actually, a journal paper that was written. And they said in CPT 2009 version, it gave this specific definition for a modifier 25, that the physician may need to indicate that on the day a procedure or service identified was performed, the patient's condition required a significant separately identifiable E&M above and beyond that other service, above and beyond. So the E&M is totally different from this one, or it's beyond that usual pre or post-operative care associated. So the E&M service may be prompted by a symptom or condition for which the procedure or service was provided. So this is part of the 25 definition for modifier 25 out of CPT 2009. And so they're saying this is what distinguishes you being able to do an E&M on that day, because you met all three components of the E&M. But based upon that evaluation, that provider found a condition or a symptom that warranted additional treatment. So you have to meet all the components of the E&M and then separately. And there's a link to that journal article. It's pretty interesting. I do that a lot for my studies right now, is a lot of journal articles. So it was fairly interesting, especially to find an article that I'm interested in. Now, payment. This is where people have a problem, and I do a lot in billing, so I like to incorporate the payment side along with coding. Many times payers do deny that as bundled, and a lot of times people aren't putting in the 25 with the E&M, so that's one reason that it's going to get denied. But if you have that 25 and the documentation is exact, is what they're looking for, can specifically say that separate service, the areas, the regions, and the outcome, then that you can uphold and say, no, you cannot deny this. These are two separate things. Now, of course, insurances have their own guidelines. Maybe they only allow 2 a year, or maybe they only allow it for certain conditions, which is possible. And that's their choice as that insurance carrier. But remember, we're still going to report them, because we do that for statistical reasons. So I did find a couple examples. There's Work Comp Ohio. They say that you can do the E&M, and maybe billed on that same day. But then they're saying, you know, include on that first visit what that significant change was, what changed in their condition that prompted this. And also because they're saying, look, the E&M you might have changed your medications, you might have done some x-rays or some lab imaging. That counts as your medical decision making. That counts as part of that whole E&M. And then you have the OMT. United Healthcare mimics Medicare. And they have treatment guidelines. Treatments are acute or chronic, not to exceed 1 to 2 a month. So they have a time frame that you can do those. And then only one service can be billed per day, based on the description of the procedure code, of course, because you're talking about those regions, anywhere from 1 up to 10. And then you can't, if you go beyond 6 months, it has to be because of some condition that the patient has, like ALS or post-CVA, some specific condition that's affecting that area of the body and causing those somatic dysfunctions. So they have a little bit more. You always look at the insurance guidelines as well, and make sure that you're doing everything properly for that insurance carrier as well. Again, there's the link for those different techniques that are used. They told 40 of them. It just kind of named them. You'd probably have to do some more research if you're interested in that, or if the doctor even said, we use this technique. Well, is that a technique that's associated with a manipulative treatment? And kind of what did that do? Did they just kind of thump them on the back and everything was good, or what exactly is entailed in that technique? So.
Awesome. Thank you.
You're welcome.
That was great. And we are going to get into our reviews here. So we always like to encourage people to leave reviews for us so we can do a better job, or let us know if we're doing a good job. And we like to talk about the ones where we do a good job, to be honest, more so than the other ones, but they're very few and far between the bad ones anyway. Right now we're up to 657 reviews on our website. So you can go over to there if you want to verify any of these. But this is the first one on September 13th, just recently, from Barbara Mancuso, which we know in our webinar land as a frequent flyer. And she said, first try, yay, I will say the Blitz helped me and I really liked watching a real person, unlike the content from the other course I took. I am now CPC CMA, yay. And then on September 12th, Abdul Ramim said, content in CCO helped me in preparing for the CRC exam. The lectures were very knowledgeable and helped me in my overall preparation. It was my first time and I passed in my first attempt. Any comments there, ladies, on these guys?
Yes, but I won't.
You know, I actually have heard that about watching a real person. I've heard a lot of people say that, not just, you know, through CCO, but I'm a teacher as well. So people like to see, you know, not just have somebody talk over, you know, watch. They can read slides and then you have somebody reading the slides to them. So they like to actually have that person there, kind of. It just feels more personal. I don't know.
Yep. And we all know, working with Alicia and watching her webinars, that oftentimes we have a certain number of slides and they go twice as long as what you think they're going to go, because we got all the great stories that go with them. But hey, they even capture my attention. She's got such a big family that most of them have gone through most of the ICD-10 code book, I think, by now. I hope not, but you know what I mean. Cool. So thank you guys for taking the time out to leave those testimonials for us. Thank you very much. So we're back to Alicia, who's going to talk about coding long-term drug therapy.
This one was a lot of fun because this is an area that when we're teaching coding, we have to talk about their specific codes used for long-term therapy use. And the person who sent in a question says, can you give me some insight in how to know when to code for long-term current drug therapy if it isn't exactly stated as such? And again, this can get very, very confusing. So what I wanted to do is kind of break it down and explain what long-term drug therapy was and some examples above and beyond what you normally see in a testing scenario, because they like to use the long-term insulin use and long-term oral anti-diabetic use, meaning you're taking a pill for your diabetes. But ultimately, what is drug therapy? It's pharmacology, it's pharmacotherapy. So anytime you're taking a drug into your body to treat a disease, you're taking drug therapy. And this could be over-the-counter medications as well, because as you know, a lot of people take aspirin, baby aspirin, and that's over the counter, and yet your provider has prescribed for you to take that. They want to thin your blood out a little bit, and that has been noted to be very helpful if you do that. Ultimately, drugs, how do drugs work? And I thought this statement was really good because it states that it interacts with receptors or enzymes to promote health. And we forget that drug therapy works on a cellular level. The code that the person was asking about was Z79.899. Now, there are two other codes that are usually used in scenarios to test you on, and that is Z79.84 and Z79. Let's see, it's not 84; it's one of the other ones, but the anti-diabetic, and then there's long-term use of insulin. Don't get that confused with Z79.899. Again, if a person is taking an oral medication for their diabetes long-term, you have a code for that. Remember, we're doing this for statistics. We want to track that. But there's other medications that are taken long-term that we need to track that the patient has had. But we can't list all of the medications long-term. It would, fill up our code set. So Z79.899 is other. And when we're doing ICD, other means that is specified that we just don't have a code for it. So let's scroll down, excuse me, and notice here some references that for LCD, and this is a billing aspect, but they're saying that if you do use these codes for long-term insulin use and long-term other drug use, you have to make sure to be able to use this, that it is in the medical record, both how long the patient's using it and the dosage that's being used. Okay, that's very, very important, but don't overthink it. There is a HCPCS code that's a great example that when I used Find a Code to get some examples, they use J0897, which is for Prolia. And this is not one that you would have probably thought of, but men who are at risk for a fracture because they have prostate cancer. So what are we going to code in that situation when they're taking Prolia? Well, we need to track that. So the Prolia would fall under the Z79.899 and then the Z85.46, personal history, malignant neoplasm of the prostate. Okay. And then it gave the reference number there for that. Then another question that I found in Find a Code that I thought was excellent, that was pretty pertinent. It looks pretty basic, but the answer that was given went above and beyond. So it says, if a person's given non-insulin injectable medications for diabetes, should we use Z79.4, Z79.84, or something different? And the answer that came through, we're going to use long-term use of insulin, okay? But that is for a patient that is going to be taking it for an extended period of time. Then we have the Z79.84 if you're taking an oral hypoglycemic, and there's like metformin and a whole bunch of other ones. But What they went on to say is, don't forget, if you are going to use Z79.4, you cannot use that if a person is temporarily given insulin to stop a diabetic reaction. So they're type 2 diabetic, because type 1 has to have insulin. And it's redundant to put the long-term insulin code for a type 1 diabetic, because it's a given. They have to have insulin to survive. However, for a type 2, they can use diet and exercise. They could use an oral medication, which we have a code for that, and or they could be on insulin. But let's say the patient is temporarily given some insulin because they just need to get their blood sugar under control. They're not going to be on insulin long term. Then you're not going to code that long term use of insulin. Be very, very careful. And that's a classic test question. So be very careful with that. Then going on, they just went on ahead and said, like I said, I found this at Pharmacotherapy. They said you could give them more information if you wanted to give a specific scenario. I think there's another example. Yeah, Wisconsin Physician Services Insurance Corporation went on to talk about this darbepoetin alpha, and it's used when a patient has anemia and they have CKD. You have to have 3 codes when dealing with that diagnosis. And I thought it was really important for you to be aware of this. Sometimes when we're doing research, something else pops up. And so I went ahead and put these on here. If you use either one of these HCPCS codes, J0881 or J0885, they're the same drug, more or less, but for the same reason. But it tells you that first you're going to code that the patient has anemia, and that's the D64.9, or there may be a higher specificity. Then you're going to code the Z79.899 for long-term current drug therapy. Okay. But it says you have to use another code to indicate the condition being treated. Okay. So just because a person has CKD and an anemia and they're being treated for the anemia, you need to say that they have CKD as well, or whatever other reason they have anemia. Some of this falls under the guidelines for anemia, but I thought it was very important that we make a note of that, because it may be something that you weren't aware of. And that is a better understanding of long-term drug use. So just to recap very quickly, that if a person is on long-term drug therapy, you're going to use that Z79.899 if there isn't another code to indicate what kind of drug therapy they're getting, like an anticoagulant or the insulin, etc. However, be very careful that there's not any additional guidelines that that sometimes you need more codes to describe the whole situation. Thus the example of anemia. And when you put in Z codes, I think when you first start out, you either go from one extreme to another. You want to code everything that you see, or you overcode stuff, or you're too scared to code something when you need more codes to fill out the full definition or tell the whole story. And that's it.
Thank you, Alicia. Hanging in there. Sounds like you still got enough breath for one more.
I think so, if we do it soon.
Right. All right, now we get to find out who's actually on the webinar. Usually we do this at the beginning, but whatever reason, I want to keep things fresh. So which of these are you? How many have you attended? Is this your first time? Are you back for more, and this is only your first one for back for more? 2 to 5 is a repeat offender. 5 to 10 liking it here at CCO, or 10 plus is a CCO frequent flyer, we like to call you. And I'm gonna fix my live stream so it all makes sense over there. Sorry guys, in the live stream we cannot get your vote, but we do have pretty close stats here for at least the people who are on the webinar. And we got 71% voted, so I'm going to count it down. Take your last shots at this in 5, 4, 3, 3.5, 2, 1. And Sharon. Wow, 27% first time. 4%
Awesome.
just their second one, I guess. Repeat offenders 19%, 5 to 10, 17%, and almost 33% are 10 plus. So thank you for your long-term people and everybody who's on the webinar today, because otherwise this would be pretty boring doing it just for ourselves. And glad you're getting value here. So I know that you can probably, it depends on where you're at. If you're on your iPad and stuff like that, you can hit some buttons there and you can say, it's kind of like emojis or something like that. If I remember, if you're on a desktop, I'm not sure that they're there, but I remember on the webinar, you can hit little buttons and we'll see little stars here somewhere. I don't know where they're at, but FYI. All right. Let's go on to our next one, which is Dear Jennifer, with understanding APCs. What's all that about?
Yeah, so we had somebody who come in with a question that they don't understand how the APC indicators influence coding. So of course they influence billing and revenue, but as a coder, why do they have to pay attention to them? And because on one hand, there's a lot of services that are bundled that have a status indicator of N, and on the other hand, their course instructs them to code them regardless of whether they're going to get a cost. So they wanted some clarification. So when we're looking at APCs, those are ambulatory payment classifications, and those are established by Medicare, and they are payment rates affiliated with your ASCs, your ambulatory surgical centers. And they deal with the OPPS, which is, I'll go into that in a minute too. So the ASC, you don't have to be, they're not Medicare providers, they're suppliers of surgical services, but they must accept Medicare and they have to be participating. They must have their own individual contract with Medicare. So they can be separate from a hospital. So if you want to move down, they can be separate from a hospital, freestanding facility, or they can be affiliated with a hospital. It used to be in the beginning when ASCs came out, you could not be affiliated with a hospital, but now they do allow hospital affiliation as well. So if you want to move that down, Boyd. And then the next thing that they talk about is the OPPS. Now you're going to hear, if you do any kind of billing or billing education, you hear a lot about the prospective payment systems. There's home healthcare prospective payment system, there's inpatient, there's skilled nursing, there's all sorts of prospective payment systems out there that Medicare has established. So OPPS is the outpatient prospective payment system. And that's how Medicare decides how much money a hospital or mental health facility. Now remember, we're talking about outpatient. So outpatient, still dealing with Medicare, it can still be at a hospital. So you got to keep that in mind there. A lot of people think hospitals only inpatient. Well, hospitals also have outpatient services. So that's how much are they going to get paid for those Medicare patients for the outpatient services that they provided. So they assign each HCPCS, each CPT code, a letter that's going to signify how it's going to be reimbursed. So then these status indicators is an indicator that helps determine things like their policy rules, like packaging or bundling. Now, when you hear packaging or bundling, we also think of things that are inclusive. So things that are all provided under the cost of one thing. So they're all bundled together, remember? And so they're paid under a single unit. And they asked for about status indicator of N, which means that those items or services are already all packaged into that APC rate. They're paid under the outpatient payment prospective payment system, but the payment is going to be a single payment, and that way there's no separate payment for those separate services. So if you look up a HCPCS code or CPT code for these particular facilities that deal under this system, then If you see that N, you can say, well, it's not going to get paid. It's all bundled into the main one. So we're going to scroll down a little bit more. And so why does a coder have to pay attention to that? Well, the same as in a facility, the same as in a physician's office, you're going to look at your NCCI edits, right? You're going to look and see, can I bill those two codes together? Are they inclusive? Do they need a modifier? Is there something I need to know about these two? The coder is going to do the same thing in this type of system as well. Those status indicators are going to tell you what can be submitted on that claim form. So under the OPPS, the surgical procedures that are performed in an ASC, they come under facility fee unless it's deemed not eligible. Well, why can you not bill something to Medicare at an ASC? So Medicare loves their formulas, and when you're dealing on the billing side, you see these formulas all the time, RVU plus the geographic index plus this multiplied by that. So they do a lot of these formulas. So they assign all these things a weight, and it's actually a percentage of what the hospital would get for those services, because it takes into account the administrative fees, the time, the nurses, the equipment, things like that, same as it does on a facility side. So these get paid a percentage when they're dealing with the ambulatory surgical center, a percentage of that same type of payment system. So they weight it. And then they have a conversion factor, which goes by your geographical area sometimes, or the type of facility or the type of qualifications they have. And that comes up with their ASC payment rate. So what can you not submit to an ASC? Something that's emergent and life-threatening. If it's emergent or life-threatening, you don't want to be at an ambulatory surgical center. You need to be at the hospital. You need to be at the ER, because they're better equipped for those type of procedures. Something that can't be performed in a physician's office, but you don't want to bring them to the hospital. So the surgery center is a good place to bring them. These are, of course, all elective procedures. Not to say it can't be an urgent procedure. It can't be emergent. So that's why those two are italicized to bring it out. It cannot be emergent. Emergent is life and death threatening. Urgent is, we deal in orthopedics. We have somebody who broke their arm, ruptured a tendon, something like that. They don't have to go to the hospital, but a surgery center might have better availability to get them in the next day or later that day or as soon as possible. Where the hospital, you got to deal with all the other providers that are using the hospital surgery services. So it may be a couple more days before the hospital can get you in, but a surgery center could get you in quicker. So it's an urgent procedure. Something that's not going to involve major blood loss or a prolonged time opening that patient up and dealing with it. You don't want to extend any of those circumstances that could cause infections, blood loss, oxygen rates, anything like that, because those services, they're not equipped for things like that. So most MAC carriers, most Medicare contractor carriers for your area are going to tell you which HCPCS code and CPT codes you can use. And they're going to say those supplies and all that stuff, they're all packaged into this payment, one payment. So you should not, most MAC carriers tell you, you should not be reporting those items that are already included. So up in the schedule we showed a little bit earlier, K1 said a non-pass-through drug and biological. So we're going to scroll down and see what the non-pass-through means. So what they're talking about is a non-pass-through is items that are carved out from that single payment, whether it's typically you might use this, but sometimes people use this. That sometimes drug, that's going to be able to be billed. That it's not their standard equipment or supply or procedure. Sometimes you might have another one. So if you don't submit those, then they're not getting paid for those things. So what they say is you're leaving the money on the table. They want that money. So if they're not included, then you could be losing out on that reimbursement. When you're dealing with the ASCs, a lot of common coding errors that they have are people are coding, well, you see this in not just an ASC, but they might be coding from that surgical report header. What type of procedure did they do? Procedure 1, 2, 3, 4, and that's what you're billing. Where no, you need to read the body of the note. So a lot of surgical coders can make that mistake. They say, oh, they did an arthroscopic knee scope of the, medial tendon. Well, okay, so that's what I'm coding. Well, once they read the note, they go, oh, wait, they did the ACL, the PCL, and the MCL. Well, that's something totally different then. So, but that didn't say that in the header. The header is usually their intended procedure, but that doesn't mean once they got in there, that's what they actually did. Submitting both an arthroscopic and an open procedure. And we know when something starts arthroscopically and they go, oh, wait, we need to get in here, and they open it, you no longer bill for that arthroscopic procedure. Now you have to bill for the open procedure. That's the more relevant procedure that happened during that surgery. This is carrier dependent, but there is an ASC modifier. So the SG, now Medicare doesn't require that you have to use the SG, but there are other carriers, and some of them are federal carriers that do require that SG modifier. Not putting the 24 place of service. That's an incorrect place of service. 24 is the correct place of service. Some people still use 11 for an office. Well, it's a surgery center. It's not an office. Billing non-covered services as covered. And that's what we're looking at in this question is those are non-covered services. If they have that N status indicator, that means that they're bundled and it's non-covered. But then of course, because these have separate Medicare contracts and specific Medicare contracts. When you're dealing with a Medicare patient, you cannot perform one of those services that are on the exclusion list that don't do these at an ASC. You cannot do it at an ASC. And if you do it, for some reason, you cannot bill that Medicare patient for the denial because you're under a contract. So in the Medicare claims processing manual, it is chapter 14 deals all with ASCs. And 10.2, they say because those prices are based lower than a separately payable procedure, and because the comparison is made at that claim level, they go claim line by line, the facilities may not be paid appropriately. If they unbundle those charges, the same as at a physician's office, you cannot unbundle your charges. The facility cannot unbundle them as well and report them as packaged. So some ASCs, some charges that you see come through an ASC are not necessarily an ASC charge. The physician who does the surgery, they are billing under their own tax ID and their own information. Purchase or rental of DMEs, prosthetic devices, and ambulance service that had to get them there or perhaps take them away from there, they're not billing. And anything furnished by an independent laboratory, of course, they're going to bill for their own. So those don't fall under those ASC charges and any services that they're on the excluded list. So there's a link there for the federal regulations. That is how the code of all the federal regulations for an ASC. So if you deal with the ASC surgery, might be an area that you want to look at. But if that ASC bills that code, that is considered to be part of another code. You're going to see this for any services that are outpatient, that it's billed. Only the most comprehensive code is going to be covered. So I understand the question was if, they learn that you should bill them. Now, remember, we talk about that you should bill everything that you do because it is statistical. However, if it's not going to get paid and you're continually billing things that are bundled, that's also a red flag to these auditors. That we've been talking about a couple of these slides now about this auditing and your fraud. If you're continually billing things that are bundled, they're going to start to send you letters and go, wait a minute, those are bundled. Please don't do that. And if you continue to do it, then they're going to start to audit your records. That's where you're going to get some of those MAC auditors coming in and starting to review your medical records. So a course may tell you you should do it. You should then go back to your compliance manager, your compliance manual in the ASC, and see what they want you to do, because they're the ones coming up with the rules for billing for their facility. So just because you can bill it doesn't always, just because they did it, we got to make sure it's not bundled into another procedure first. So.
Thank you, thank you, thank you.
Mm-hmm.
And that was great. And I believe we have a poll here as we enter into the bottom 9th of the inning of our webinar here. Are you a member of the CCO Club? We talked a little bit about it. We're going to talk a little bit about it right now. And we might have a special guest joining us here in a second. And I have just figured out that I closed something down that I didn't want to. So we're going to go with this one, launch. Are you a member? Yes, no. Or no, I didn't know about this thing called the CCO Club. We want to know what that is for a question. What that is as you would answer it. Put it that way. All right. We're almost there. We got 65%, I think, done here. We have had a couple of iterations of the CCO Club over the years, but this one is holding pretty steady now. Glad to say. So I think we got 75% here voted, so we're going to close the poll now and share our results. And yes, says 50% of people here on the webinar are in the current CCO Club. No, they are 30%. They have not decided to join, and about a quarter are not even knowing what our CCO Club is. So great. Here's our opportunity to talk about it. And I think joining us as I close this is a special guest in the bottom of the 9th inning, pitch hitting for Alicia Scott, Miss Lorene Yondra.
The Alicia lookalike who quickly ran and tried to pitch in a little. Poor Alicia. Oh. So I thought I'd come in and help do her last question, and I won't do it as well as her, but at least we can get you the information and see if we have any questions that came through in the chat. So thank you.
Awesome. Do you want to talk about the club a little bit and what you think the advantages are for the people out there?
That. Yeah, I'd love to talk about the club. I feel so weird because I'm used to driving, so I'm like just sitting here watching the show. It's kind of nice actually. But the club is something that started a while ago when Boyd started to do these recordings, and Jesus, our manager, said, well, why don't you do a replay club, because people want the recordings. And as a matter of fact, I think I saw a couple questions in the chat tonight about getting the recording. So that's how that was born, was giving these monthly Q&A webinars a home for people to be able to watch them later instead of live, and be able to do get CEU credit for watching them and those sorts of things. Now we've got lots of content besides just the replays. We've got articles and other CEU opportunities, and we have a whole hour-long webinar that Alicia and I did where we go through all the benefits of the club. So if you go to cco.us/club, check that out, and if you're not sure what it's all about, that will give you all the details. And if you have any questions at all, just send a note to the help desk. If you go to cco.us/helpdesk, just tell them what your questions are and they can help you. There's a couple of levels that you can choose from, whether or not you want to include find a code with it or not, but we're happy to help you figure out if it's a good fit for you. We think it is. Oh, and one of the biggest benefits I do want to say is if you've ever purchased a course or a blitz from us and you are a club member, you get access to that course indefinitely. So every year when we're updating it, you can go poke your head in if they want to see if there's a new lecture on something. You don't have to retake the course. You can if you want, but the information's there. I know for myself, when I've purchased courses on the internet, and I had a good intention to sit there and get through it all, some things on nutrition and stuff like that. It was a 3-month pass, and I'd come back and my time was up, and then I had to pay again. So with the club, for that low monthly rate, not only do you get all the replays from the webinars, you get access to all the courses that you've ever taken from us. So I think that's a big plus.
Which is good too, Laureen, because I'm in, like I said, I'm doing my MBA right now, and I was coming up
Wow.
with a PowerPoint for a presentation, and I'm like, oh yeah, what did they say in that course? And I went back to one of my first classes, and I can't get in my class anymore. And I'm like, I'm still in the program, I'm still paying money, but that class won't let me in that class anymore.
Yeah,
So,
it makes a difference. You just feel
I
like
know.
you bought it, you want to keep it,
Yeah.
so. Plus you get
Yeah.
to have continued access to us.
Yeah. All right.
All right, do you want to go to Alicia's last question here? Oops.
I'm going to do my best.
That one, let's go back. Yep, there we go.
There it is. So surgery coding errors to watch for. So the questioner asked, I have a job opportunity to code for surgery, but I'm nervous about it because my experience in coding has been limited to peds. Is there any advice or resources you can point me to so that I can, as Alicia says, increase my knowledge base? So I did have an opportunity to look over the answer sheet just before. So what she did is she found a great article, and I don't know if that's her first name, Jitendra, and it sounds like someone who might be in the club. That name sounds very familiar. At any rate, on the answer sheet is the link to the website where Alicia got a lot of this information. Maybe Boyd could share that in the two different, or three different audiences, four different, right? We have LinkedIn going too, to share that with them. But here was her summary of those notes. One of the trouble areas is knowing when to code open versus arthroscopic procedures. And I know in teaching coding over the years, this is a big thing that I stress with the students. Look for things like the word scope or portal. Sometimes you'll see that word portal. I used to think when I was learning coding for the first time that if it was arthroscopic, there was no cutting into the body. And that's not true. They obviously have to make little slits to get the instrumentation in. And normally it's more than one because you got one for the scope, one for the instrumentation, maybe two for the instruments. So that's what you want to, those are the clues that you want to look for in the reports. Focus on the procedure heading as well to see what was that, and then go into the body of the report to see what was actually done. The next thing was coding for, oops, you got to go back a little bit, Boyd. There you go, coding for lesion destruction per nerve, not the level. When we start talking about the spine, you always need to understand, are we talking about the individual bones or the levels? So if you're doing a radiofrequency ablation of lesions and they say it's at the L2, L3, and L4, well, then you have 3 levels. But sometimes coders get confused because they're used to coding for facet joint injections. Well, if it's a joint, it's going to be in between those levels. And using the L2, L3, L4 example, then you would only have 2 joints in between those 3 levels. So that's another tricky area. Okay, now the next page. So coding the number of lesions incorrectly. This one was very interesting when I was reading it. This has always stumped people over the years. And then I wanted to go refresh myself because it's been a while since I talked about it, make sure there wasn't any coding changes that I wasn't aware of, but it's still the same. And I was asking Boyd, I don't know, Boyd, were you able to pull up Find a Code?
Yes.
I just wanted to use this also as an opportunity to show, how we are, I'm trying to think of the correct word to use, not partners, but we like each other. Find a Code in CCO. We promote them with our club, and they've also built in, if you could type in that box,
You can click in,
1700.
you can click in there. I've just given you control, I think. I hope.
Oh, okay. Let's see if that works. Oops. So what I'm doing is I'm looking up that CPT code that Alicia referenced in the document, this 17000 destruction code. And if you'll notice, you'll see where this one says first lesion. Thank you. First lesion. And then I'm going to click this right arrow here to go to the next code in the range to 17003. And if you'll notice this one, it says 2nd through 14 lesions, and then that keyword each. So if you had 12 lesions, you report 1 of the first code and 11 of this code. But here's the reason why I wanted to come here to find a code. If we scroll down a little bit, does it scroll for me? It's not working. There we go. In Find a Code, they've got this thing. I can get it to, doesn't like me, boy. Can you scroll down a little bit? Okay, and where it says coding tips, if you click that plus sign, that'll expand that section. Did I goof? It went black for me. Is it? Can you see it? He's like, why'd she have me do this?
Okay, go ahead.
All right, then click on the plus sign next to coding tips, or it says 7 tips.
Yeah.
And you'll see right there, it says CCO training video. And if you click that plus sign, what the good folks at Find a Code did is they went and they scoured our YouTube channel, and if they found matches, they linked it here. And we have happen to have a video.
I don't know what
Go
happened
down there, and you don't have to click on it, but you see where it says for more information on how to code lesion removal, check out this training video from codingcertification.org. And when you click on it, it takes you to our YouTube channel to a little video clip of a previous Q&A webinar where we talked about it. So I just thought that was kind of cool, and I thought I would take an opportunity to you know, share that very old picture of me. Do not.
2012. Yeah.
Yeah, but it still applies. It's still current information. So what I just explained is on this video. So at any rate, we can go back to the Google Doc. So that's a tricky point with those lesions. Sometimes people feel you can only code one of that 17003, and when their word in there says each. And then of course there's the 17004, and that's when you have 15 or more. So you drop the first 2 codes and you just stick with that one once you have 15 or more, and that's only 1 unit. The next tricky area is reporting both arthroscopic and open techniques for one procedure. What you need to understand here is that sometimes the intention might be to handle a problem just with a scope. They don't plan on doing open, but they have to convert it to an open procedure. And if that's the case, then you only want to code the open procedure. That's the gist of that one. Wrong procedure code for debridement of ACL. So when there's no more specific procedure codes, and medical coders need to report or use unlisted codes. We don't like hearing that. I remember I had a job where I worked as a researcher, a coding help desk, and they would have questions like this, and 80% of the time, the answer was, you have to use an unlisted code. They're like, no, no. But that's what unlisted codes are for. If you do not have a procedure that matches what you're doing, then you use the nearest unlisted code to what you're trying to describe. And of course, when you send in the documentation, if it's a lot like another code in work effort and similar technique, then state that in your letter to help get the right reimbursement. And an example here was for debridement of cartilage. Oops. Now I know what they feel like when I'm driving. We have to report CPT code 29877, but for arthroscopic debridement of an ACL ligament, it has no specific CPT code. So therefore, the nearest unlisted code is the 29999. And oftentimes, just a little hint, those unlisted codes are the ones that end in 9, and they're at the end of sections. So make sure you look at all of the unlisted codes to get to the closest unlisted one that you can. She goes on to say, in the same way, medical coders use CPT 29828 to code arthroscopic biceps tenotomy rather than using the unlisted code. So you can see the choices here. 29877 is arthroscopic for the knee, and 29828 is for the shoulder, but then the 29999 is the unlisted. So if your 2 descriptions do not fit what you did, it's close, but it doesn't fit, you need to use the unlisted code. I didn't say I quit. All right. And then the next one is failing to code for different polyp removal techniques. So 3 that she listed here as examples, you can remove a polyp with cold biopsy, hot biopsy, snare biopsy, and there's a couple other techniques. If you remove 3 biopsies with the cold technique, you only get to report that code once. But if you report 2 with the cold technique and 1 with the hot technique, you can actually report 1 code for each of the techniques. So a lot of people don't realize that, and they're losing out on reimbursement. If you have to switch up techniques, you get to code both codes. And of course, the multiple surgical modifier or reduction would apply there. And it goes on to say, when all these techniques are used together in different polyps, we have to report each technique separately. The number of polyps does not matter, because in the description, when you read the code, it says polyp or polyps, you know, that S in parentheses. But if you have multiple techniques, then you can report them separate. Did I get them all?
You did.
Yay!
Awesome. Awesome, awesome. Great. Good pitch it. You knocked it out of the park. Okay.
Let's
Let's see.
laid out.
Survey. Now I see why it gets way on you. It's my hypersensitive mouse. So how did we do here? We've just finished up the last question that got prepared, and our webinar is basically over. We're going to give the prize out now here after this slide. So, but please, I put the link to this survey in the chat. So please go on over and let us know how we did. Would love to hear more and see more about what you guys think about this. And we have a winner that our background people have been checking on to make sure that they were here. And I'm just going to check and make sure, and looks like they are. So I'm going to go back, because it looks like we have a lot of chatter here about who left the webinar because of their health issues.
Oh. Are you trying to make sure they're on?
Yeah, exactly. Susan Mills is our winner here tonight. Susan Mills.
Congratulations, Susan.
Thank you for attending.
Sorry, answering questions. Sorry.
Yeah.
So you just need to open up a help desk ticket, cco.us/helpdesk, and let the help desk team know what prize you would like. If you want a Blitz video package, or if you want a year of the CCO Club Basic, or an hour session with one of us, they'll be happy to set you up. So congratulations.
Awesome. All right, now we're going to go into our prepared chat, and we'll see what goodies our team has put together here.
Yeah, they were kind of quiet tonight, so I don't think we had too many.
Great. All right. So here's our first.
Okay, so what illustrations in CPT should be marked up for the CPC in my code book? Basically, I would do whatever your weak areas are. I know when we do our lectures and we do each of the organ systems for like CPT, we kind of review anatomy a little bit in the beginning. And that's normally when I would tell you, oh, you know what, mark this on the heart anatomy picture, or this on the digestive system. Do you do that, Jennifer? Do you do a little like anatomy review when you talk about the CPT coding and stuff?
Yeah, we use it for when people, yeah, if they're having trouble remembering particular bones or particular tendons or muscles connected to a bone, and you know, the things that they kind of forget, we say put it back on that illustration, and that way when you're going, what does that mean again, and where is that, you can look at that illustration and go, oh, yep, that's right, and that's the section I have to go to. I forgot. Yeah.
And if you go to our YouTube channel, Medical Coding Cert, and you type in, you know, I don't know, like cardiac or whatever, you'll probably see where we've shown our handwritten notes on our little charts and stuff. So you could, you know, look at it that way. But basically, you want to do what's useful to you. If you're pretty good at that anatomy and you don't need to worry about it, then don't worry about it. For me, with the digestive system, I kind of highlighted the accessory organs in a different color. and versus the traditional, jejunum and the ascending, transverse, descending, all that kind of thing. And you'll notice sometimes too, like, I don't know if they fixed it, but the last time I looked, they didn't put, I think the descending or the sigmoid, so I had to label that so that I had all the pieces there. The reason I do that is if I got a multiple choice question on, say, medical terminology or an anatomy question, and I went there, it would help me figure things out. And I will say one time I took an exam and it was a question about one of the valves of the heart, and I forgot all about going to look at the illustrations. And when I went home, I went to, look it up. I said, I can't believe I couldn't remember which valve that was. And all of a sudden it dawned on me, and I turned there, and there it was labeled in the front of the CPT book. So half the time it's just remembering what you have. Be aware of where they are. And they've changed them over the years. When I took my exam, they were all in the beginning together. Now they kind of try and put cardiac stuff in front of the cardiac system. I kind of like them all,
Yeah. Yeah, there's some in the beginning, and then like when you get to specific areas, like each little bone of the hand and all the little carpals and things, then that might be back in there. But then HCPCS has them too. So you've got different books to look at. So
and ICD-10 has images. So kind of be aware. I know for CPT, they kind of have in the beginning a table of contents of illustrations. I don't know, on an exam and you're stressed, I doubt you're gonna go, oh, let me go look at the table of contents and scroll all the way down. You kind of just got to know, like, I know, like whenever I have a question on the rule of nines, like for burns, I go, okay, I know there's a picture in my ICD, I'm gonna say 9, ICD-10 manual, and they've got one of the baby in the CPT manual. So, but I now know that because I flipped through it so many times. So half the battle is just knowing what you have. It's not even so much marking it up. It's just knowing where it is.
Knowing that, that it's there. Yeah.
So flip through, like normally I would tell the students, like a day before they're ready to sit for the exam, flip through every page of your manuals and just flip through it and just go, oh yeah, I forgot about that picture. Oh yeah, oh yeah. And now when you are taking the exam, at least you'll know it's in there and you can go, find it and think logically, okay, how is CPT setting it up, this year? Okay, digestive system is in front of the digestive system in CPT. Okay, that makes sense. And now you can at least figure out where to go get it. So, all right. How can I get a copy of the Q&A notes discussed in this presentation tonight? Well, that is also a benefit of the CCO Club. All of our recordings and handouts are shared with our club members. We open this up to the public so everyone can kind of take a peek in and see what we're like, but all the goodies are for the club members. So we really want you to be a club member. But I will say we have quite an elaborate process. When Boyd finishes tonight with the video and fixes it up a little, he hands it off to transcriptionists. They type it up all nice in a nice little, template that we like, including the slides. They'll pull the slide in and then have what we said below it, and then the next slide and what we said below it. So it's a really nice handout packet. In addition to the answer sheets that you see us pulling up, those Google Docs where all of our research notes are on, you get those as well. So join the club if you'd like them and to see a recording of this webinar. Did I miss anything? I'll let you.
Sorry, I'm answering a question.
Oh, are you? I know, right? You want to read this one?
I'm sure. Yeah, so somebody who's looking at, they just got their CPCA, which is great. They have 20 years in the medical field, 18 they've been in clinical, and then they've been doing the last 3 dealing with the revenue billing, claims collections, the administrative department, and coding radiopharmaceuticals. So researching, they love to research, which is great. It's one best way to learn, but they want to branch out into a broader foundation in coding. What area or type of coding would we recommend? Well, I started typing an answer to this when I saw somebody else already typed an answer to this. So I started saying, for one, what area you want to get into. I was thinking in my head that pulls up like specialties. And that's that. And I would say, what do you like? I mean, do you like OBGYN could be kind of difficult. You know, cardiology, very difficult. But, you know, if you have a knack for that and you like it, my girlfriend loves cardiology. I don't want to do it at all. So definitely you could look at that, or based on your foundation that you already have, you'd be great as looking at risk adjustment would be a really good one. Understanding that whole clinical background,
Yeah.
what should be in the medical record, what you can extract out of that medical record would be a good one. It depends on how you read that question. So what were you
If
thinking?
you like
Lori?
researching, you know, it's the backbone to everything you've done, you're probably really good at it. So, you know, being that detailed oriented auditor came to mind for me when I read this, if that's something that you like to do, where you're kind of making sure the I's are dotted and the T's are crossed of other people's work. It just, you know, you can go a little bit slower and be more methodical and dig in, because with that, it isn't always trying to get a whole stack of coding out the door. You know, you're actually looking for patterns so you can help either improve a physician's documentation or help improve a coder's accuracy, that kind of thing. So, good questions.
Next.
Oh, we did get
Long-term
another one.
diabetic meets. We got two more. This is second to the end.
Oh, okay. All right, a diabetic patient visits the emergency department with non-diabetic condition. Do we need to code long-term diabetic meds? This is an Alicia question.
Definitely an Alicia question. I'm trying to shoot from the hip here. If the diabetes is not in relation to this condition that they're being seen for,
The non-diabetic condition, yeah.
Yeah, then you're not going to code those long-term medications because it's not affecting the condition that they're being seen for. That's off the top of my head, that's what I would say without doing any
Yeah, I would
research
agree with
into
that
it.
too, unless they say something like, you know, they have a wound. Well, wounds, we know diabetes affects that. So then you might, you know, want to code it. As far as the meds though, I mean, you're going to code that they are diabetic. As far as the med usage, I'm not sure if that's needed for the ED department. This would be a good one for us to develop with an answer sheet and go into all the whys and wherefores.
Yeah,
So
definitely.
we will
Yeah.
put this in for a future Q&A webinar. Do you recommend getting CRC or CPMA as your second certification? I'm kind of leaning toward the CRC, just because I think there's a lot of opportunities out there work-wise. They tend to be easier on new people entering the field as far as giving them a chance and hiring them. CPMA, if you've been coding for a while and you're like the person in the previous slide, you know, doing auditing, that detailed kind of work, that might be for you. They're kind of different. In some ways, they're the same in that there's a volume of material you're going through to determine things, but
now remember,
yeah,
that's going to change come 2021. CPMA, not that the job is going to change, but the type of information we're looking for may change for CPMA in 2021 with the new Medicare rules coming out, with their proposed rules, because they haven't finalized them yet.
You mean
So
for the E&M?
for E&M, and that's CPMA does a lot of E&M, but because that's probably the majority of what goes on anywhere. There's more E&M services than surgical services, but both of them require certain amount of time experience in the field. CPMA, they suggest 5 years experience before obtaining that one, and I believe CRC is similar, because you need to be able to review, you need to be able to pull out the pertinent information. Is that correct or no?
Well, they obviously, all specialties will prefer people having, you know, more experience, but with CRC, they will hire newly certified people more than any other specialty that I've seen. So, and that's, I think Alicia had explained it to me that they tend to, for new hires, they actually put them through an in-company training where they're going to make sure and they're going to check their accuracy levels or whatever before they kind of set them loose. That's my understanding. But so depending on, in my opinion, depending on the person's experience, if they don't have as many years, I'd go for the CRC. If they're pretty established and they've been coding, like you said, for 5 years, then, you know, go for the CPMA and talk to people that are doing work in those two fields.
Yes. Yeah.
You know, what appeals to you, you know.
Well, and look at your area. What's available? Do you have people hiring for CRCs? Do you have an insurance company close to you? Are you near a major city like Lexington, Kentucky, or, you know, some of the areas where Medicare, MAC carriers are or something? They may be looking for CRCs more than, you know, CPMA. You need to work for a particular company, perhaps. So if you don't have something available in your area, remote for either, you know, I don't think remote is good for either of those. Depends,
But
you know.
but
Yeah.
for CRC, there are a lot more remote opportunities than there are for
Yes,
CPMA.
I knew it was CPMA.
You know.
Yeah. Yep.
How do we do, Boyd?
Excellent. You're
All
at the
right.
end.
Yay.
So I just want to remind everybody that we have lots more free stuff over on YouTube at Medical Coding Cert. We have grown this channel now to over 1,200 videos, closing up on 1,300 videos, 26,000 subscribers, and almost 3.5 million
Wow.
views. So proud of that.
Yeah.
And thanks to the team here. We're going to get 20 or 22, something like that out of this webinar. So that's where we get all these videos from. That's where they're going. All right. So
And
thank you
like
again.
and subscribe and become
and
a bell. I learned that's a thing. You gotta hit the bell so you get the reminders.
Yeah, and of course, we just got approved for, I didn't get that on the slide, we just got approved for LinkedIn Live on the beta side as well. So we're streaming over there as well. So we noticed that some people during their workday, they're in LinkedIn, so that's a little bit easier for them. Maybe they get blocked at Facebook or YouTube. So that'd be a good place for you as well. And if you need AAPC chapter presentations, tell us about that, Lorene.
Well, I know Alicia's been doing a lot of in-person ones. So if you are near where Alicia is, where is she currently now?
Mid-Texas. Mid-North Texas. North Mid-Texas.
North Mid-Texas, okay. But you know, she'll travel a little bit. But what we've done is we took our most popular subjects and we've recorded them so that if you can't get a local speaker, you can arrange for to have one of our presentations, and there's different methods. It could be a live one, but we're remote, just like this webinar is exactly how we do it. Or it could be a recording that you hit play with your people there. We could be there to field questions at the end. So there's a couple of options, but if you go to that website there, cco.us/remote-presentations, or the contact us, you'll see where it says remote presentations, and request to have one of these. We're happy to do it. We don't charge. It's just our way of, you know, helping the community out and getting our name out there. So.
Passing on
and
knowledge.
A reminder in the chat is a link to the survey. We'd like to hear from you about how that all happened for you, if you enjoyed the webinar here today, and if we can make any improvements. And a last reminder about the CCO.US club here at CCO.US. And in the handout in the section is all the links that we like to give people. Also the link to our end of summer sale. Again, that's still going on till Saturday midnight, I believe. Is that right? Something like that.
Yep.
I'd have to go check.
Yep.
No, that's what it said.
One of the links on here is called the CCO proven process, and if you're new to CCO and of the 25% people here, you know, we have a process that we like to take people through from beginning to end. If you're looking at coding for the first time, or you're looking for that next certification, you can map that process on top of whatever you're doing, and that's a free resource to get more information about that. All right. So
Good
I think
reminder.
that takes us to the end. That's the team as we see it right now.
Gonna have to update our pictures.
Yeah, absolutely.
Yeah, I think
I'm a blonde
Alicia's the only
now.
one who did. Yeah.
Thank
All
you,
right.
everybody, for being with us here tonight. We're going to let you go. And until next month, we'll always here the second to last Thursday of the month, I believe.
October
And
24th. Yeah.
October 24th, right? Somebody's on the bus
Yep.
there. I think
Yeah.
you saw that, yeah. And I'm sure Alicia will be back with us 100%, 110%, so she can drive
Yeah.
next time. All
Yeah.
right. Thanks,
right,
guys.
everyone.
Thanks for Lorene for jumping in at the last minute to cover
No.
for Alicia. I'm sure she appreciates it.
No, I appreciate her. I saw she was hacking away. So let me put a face on.
Right. Totally.
Thanks everyone. And thanks
Thanks.
Lori, Sylvia, Jesus, all the ones in the background helping us.
Thanks, guys. Until we meet again.